Hi, I'm Frank Spear. I want to welcome you to this course. What we're going to do throughout this particular course is we're going to talk about occlusion from traditionally where it was to where it is today. We're going to talk about different occlusal concepts, the different philosophies that have existed for 30, 40, 50 years. We're going to really end up talking about the science we have today and how that impacts the way we think about occlusion today relative to muscles, to joints, and airway. And so it's going to be a bit of a historical journey, but it's going to end with some very current material that will impact the way we actually deal with occlusion. So to start the topic, our occlusion seminar is called Demystifying Occlusion, and there's a reason it's called Demystifying Occlusion. Is traditionally, occlusion could be very confusing. And so what I want to do in this lesson is walk you through what I think are the critical questions that you really need to ask yourself about your patient, and specifically about how you would alter the occlusion for your patient. And I use this quote from George Bernard Shaw because it really reminds me sort of my own journey in occlusion. And the quote is, "Beware of false knowledge. It's actually more dangerous than ignorance." And what I mean by that is, for myself, the way I was taught in the 1970s, I was taught that the approach to occlusion from my school was the correct approach. And I used that as justification to treat a lot of patients that today I would honestly say probably didn't need treatment at all. And that's where I think that we have to be careful of the false knowledge about occlusion, because sometimes it leads us to do things that in fact probably aren't necessary. So when I think about our seminar and what I tell our students at our seminar is I think there's really a couple things that dentists they want to know about occlusion. The number one thing that I think people want to know is, when are you at risk? In other words, am I about to get myself in trouble by treating this patient? Am I about to get myself in trouble if I prep that second molar? When are you at risk? And occlusion truly does have times we're at risk. This is a young patient. He's 21 years old. He lost the teeth in a traumatic accident. These photos are from 1986. Incredibly deep overbite, a lot of tooth wear for 21 years of age. We had implants back in the mid-'80s, so we put some implants in, restored him. I was happy as can be. He was happy as can be, until the day he called my office and said, "Hey, I think my bridge is loose." And when he came in to see me, it was more than loose. He handed it to me. Unfortunately, he handed me the bridge and the abutments. The abutment screws were all still up in the implants because he had broken them off. And so is that a real risk in some patients? It is. And what broke it? Occlusal forces broke it. So we have those kinds of risks that we want to address. And that's a more complex problem. That's really a bruxism attrition kind of problem. And then I think the other thing that most clinicians want out of a course on occlusion is they want to know that they can comfortably treat more complex patients, again, without getting in trouble. So for example, here's a patient that really requires her entire maxillary arch be treated. Do you do it 2 teeth at a time, or do you in fact do it all at once? And for a lot of dentists, it's very scary to think about prepping all those teeth at once. Yet once you understand occlusion, you understand what to look for to evaluate your risk. Here's the final impression. I prepped the whole upper arch. There is no occlusion existing anymore. Here's her provisional restoration. So we need to understand, so when we remove an occlusion like this, when the whole arch is prepared, how do we reestablish it? So I think it's staying out of trouble and then comfortably treating more complex patients. Those are 2 major things most dentists would like out of occlusion. For me, I've sort of narrowed all of that down to a series of questions that I think we have to answer about our patients. And so I'm just going to walk you through sort of the questions that I think for each patient where you're going to be doing some treatment, what are the questions about occlusion that you probably need to answer? So I'll start with the one I get asked the most, and that's quite simple. Can I use the patient's existing occlusion and be successful? So let's take a really simple case. This patient came in to see me because he'd broken the palatal cusp off on an upper left second premolar. And, you'd say, well, simple, single tooth, put a crown on it, you're done. But if you look more closely, you'll notice that the first premolar also had fractured the palatal cusp off and has a buildup. If you could actually do the exam on this patient, you'd notice the upper right second premolar has a big crack in the buccal cusp. If you actually, again, were to do the exam, you'd notice there's also perforations of the molars of gold, and there's actually cracks on some of the molars as well. And so as you start looking at this patient, you realize virtually every posterior tooth, except perhaps the upper right first premolar, has significant damage that's done by occlusion. What's fascinating is if you're thinking about, well, can I just do the single crown and be okay? And you know, in modern day, we do a nice all ceramic crown on it, but look at what he's doing to his own teeth. The likelihood of you being able to get away putting a single crown in his mouth and having an all ceramic crown be successful long-term on that premolar is not very good. So you say to yourself, well, how can somebody do that? How can somebody destroy their posterior teeth like that? And yet, look at his anterior teeth. If you look at his anterior teeth, they have almost no wear at all. So that gives you some ideas about what's happening with his occlusion. He actually has a mild anterior open bite. That's the only way he can put all those forces on his back teeth and not wear out his front teeth. So the way we answer this first question is you start looking at your patient going, are they successful now? Because if your patient's not successful today and you don't change anything, there's a high likelihood it's not going to be successful in the future. Now, the next question then is, okay, so if I change his bite, will I be successful? So here's the same patient. He came in after my initial exam, a few weeks went by, he came in to prep the upper left, and sure enough, I had told him there was a crack in that premolar on the upper right, and by the time he'd come in, that buccal cusp had actually fractured off. So now the question is, okay, we're gonna reestablish his occlusion. What kinds of parameters do we have to put into that occlusion? And right now, I've only prepped the upper left in this photo. But the truth is, to really manage his bite ideally, you could do just the upper left, but you would need to equilibrate the teeth on the right side until we get his anterior teeth in contact. Because we're going to, ideally in most patients, not all, but in most patients that are having significant problems in their posterior teeth, we want to use the anterior teeth for guidance to protect the back teeth. In his case, he actually chose to go ahead and restore the upper right at the same time. And so we've got the upper left all prepped, and now we move on, and I've prepped all of the posterior teeth. So the question then becomes, so if we prep all of the posterior teeth, now really we've taken away his old occlusion completely, how do we reestablish the new one? And I think you have to work through this logical process with your patients about when is it safe to use the existing occlusion? If I choose not to use the existing occlusion, what do I need to do? Is it a bite adjustment that needs to be done? Is it restoring some teeth? Is it moving some teeth orthodontically? But the goals will typically be to end up using the anterior teeth to help protect us. Same philosophy when we talk about tooth wear. Here's a 32-year-old dentist, actually, who came to see me, and look at how much wear he has on his anterior teeth at age 32. The questions I get asked all the time from dentists are, so if I treat somebody like this, how do I know my treatment's going to be successful? How do I know that, in fact, the patient's just not going to do to my porcelain what they're doing to their own teeth? And again, the first thing you have to learn is you have to start looking at what kind of tooth wear is it? Is it wear from erosion? Is it wear from attrition and grinding? And if it is from attrition and grinding, which this is, you need to look at the patterns of it. Is it the patient going out onto their front teeth and grinding end to end? That's very different than somebody grinding back in a retruded position. And so the way we start thinking about occlusion as we go through each of these questions is you have to look at what the patient's doing, and then you develop an occlusion based on what they're doing, how they're grinding. In his case, for example, a patient that sits and grinds end to end is actually pretty predictable to treat because they're not going in and out, there's no pathway kind of wear there. And so in his case, I actually did very conservative restorations, veneers on the upper anteriors, veneers on the lower anteriors, and the key is to make sure that when he's in an end-to-end protrusive relationship and grinding all over, that everything is just smooth and the load is distributed over multiple teeth. So again, it's just how we think about occlusion is based on what the patient's doing, whether they're destroying back teeth, whether they're destroying front teeth. If they have tooth wear, what's the etiology of the wear? If it's from attrition, what movements are their mandibles doing that's causing it? And that's what then helps you design the final occlusion. Other confusing elements of occlusion that we need to address. Do we use night guards? If we use a bite appliance, what kind of bite appliance? And again, it comes down to what are you using the appliance for? And is it a muscle problem? Is it a joint problem? Is it an airway problem? So all of those kinds of things, what I want you to start realizing is as we go into this and throughout this course and the upcoming courses, is the goal will be who is your patient? What is the problem they have you're trying to treat? Because there isn't one answer for all of these things. It's really, here's the patient, here's how they present, this is my decision because of how they present. Same thing with pain. Patient shows up and her chief complaint is, I said, how can I help you? And she's right in the chair at the initial exam pointing right at her temporalis muscles. She's in pain. And so, okay, how do we diagnose? Is that muscle pain from an occlusal problem? Is there some joint component to that? All the different possibilities. So we need a way to work through when we're trying to develop whether we do anything to the patient's occlusion, whether we create an appliance for the patient. We have to really understand what are the diagnostic procedures we go through to help us know what's right for her. So just like tooth wear, patients who present with pain need the same sort of methodical approach to working through the process. We also are going to have patients where sometimes it is beneficial to actually adjust or equilibrate their bite. There's patients where you may want to just do a few restorations, but their occlusion would benefit tremendously if you changed how the occlusion fit together, but you don't want to restore a lot of the teeth, or you might not be moving any of the teeth. And so we need to walk through, so when is bite adjustment the appropriate treatment, and how is that bite adjustment done? Do we use, quote, centric relation when we do that bite adjustment? When do we not worry about centric relation when we do that bite adjustment? So again, I want you to kind of think about, these are all the questions that come up that make occlusion confusing. But in reality, once you learn to evaluate your patient for the specific entities that need to be assessed, you'll be able to know what the appropriate treatment is for your patient in terms of the occlusion you develop for them. And then, of course, if we do decide to treat more complex problems, we need to actually know how to do the procedures. So I get asked a lot about, well, when do you do face bows? When do you not do face bows? If you're prepping, in this case, all the posterior teeth are prepped in this patient. How do you make bite records when you prep all the posterior teeth? How do you know the vertical dimension of the bite records correct? All of those things are part of the technical aspect of occlusion. Again, questions you have to be comfortable with, otherwise you tend to just do one tooth at a time because you think it's safe. But it's not very efficient, and it also, a lot of patients are treated much better if we do more dentistry to give them a more ideal final result. And then, of course, we get into the current issues about occlusion. And really, the current issues about occlusion are, how does the patient's joints and how does the patient's airway change how you think about occlusion? You know, do we actually have to move the mandible forward to build the occlusion in a different place? Do we build it where they are and use an appliance to move it forward? Do we not need to move them forward at all? So we have to have some way of assessing joint condition. We have to have some way of assessing airway. And when we diagnose that either of those issues exist, we have to have some protocol to decide what do we do with the occlusion. Because both joints and airway alter the traditional approach to what we do with occlusion. You know, when I was trained, occlusion was pretty simple. The goal was always a class 1 occlusion. And class 1 occlusion, you had the nice mesial buccal cusp of the upper molar fitting in the buccal groove of the lower molar. And if you did that and you had anterior guidance, everything was going to be good. Today, because of our knowledge of joints and airway in particular, we're much more focused on what's the appropriate relationship of the maxilla and the mandible to each other. And once we choose that relationship, where the mandible will be relative to the maxilla, which is strongly influenced by joints and by airway, then we can start thinking about how we establish the patient's occlusion based upon that information. So the purpose of this lesson really is to just give you an overview of sort of where we're headed throughout this course. These are the questions we're going to be answering as we walk through this series of lessons and courses from the Demystifying Occlusion seminar. So I hope that gives you some food for thought to start with, and I look forward to seeing you in the next lesson.